Welcome. Hi, Joe. Hi, Cindy. It's so good to have you with us today. We are going to learn a lot about how health systems and HFAM and Maryland Hospital Association and so many skilled nursing centers have had to endure things unimaginable, but you all helped to make them very imaginable, and I think have a really nice story to share on what true collaboration can bring in the midst of such an awful pandemic that we've been faced with. So you're all heroes to me, and I can't wait for you to kick off our call, but I'd love for you to kind of give a little introduction of yourselves. And Joe, if you want to tell a little bit about you and HFAM, that would be great. And then we'll go to Cindy.
Oh, thank you so much for having us, and it's good to be here with my dear friend and colleague, Cindy. I'm Joe DeMattos. I'm the president and CEO of the Health Facilities Association of Maryland, HFAM. HFAM is the oldest and largest post-acute association representing nursing homes in Maryland. We are 72 years young, and I have not been here for all 72 years.
Go ahead, Cindy. Thank you, Joe.
And I'm thrilled to be here with Joe as well. So Cindy Kelleher, I am president and CEO of the University of Maryland Rehabilitation Orthopaedic Institute, but I play another role for the system. I lead their post-acute care collaborative, which includes a lot of my partners, including skilled nursing homes and associations such as Joe, as well as home health and hospice.
Terrific. So I want to take you back a couple of months. And I know there hasn't been a lot of sleep in between, but when you kind of got the call that says, we need some help, and Cindy, who do you know, right? What happened in your world, and how did you know where to turn?
So when I did get the call, our biggest concern was what happens downstream as we start to fill up our acute care hospitals. And Joe and I actually didn't know each other well. We knew each other in passing. And Joe had invited me to a program that HFAM was doing. So I met Joe and, we kind of started to chat. But that day, I knew I had Joe's phone number. I called Joe and said, Joe, we need to work this out together. And he was already way ahead of me and thinking through what we needed to do, for the citizens of Maryland as we headed into the surge.
What about with your skilled nursing partners? How did you know who to call there, or how did your system know who to call there?
Yeah, we had already been working on our post-acute care collaborative work. So we'd already been in touch with a lot of our skilled nursing facilities. We'd actually been meeting through, a couple of venues, looking at some software, looking at readmissions. And so we definitely knew our skilled nursing partners. And so we just started to call them with the support of Joe. And so we started to talk to them about, what did they need? What did they see coming? And it was really more mutually, how can we help you? And what do you need from us?
What about same type of question, but with other hospitals in Maryland? Obviously, University of Maryland wasn't the only one affected, but this is statewide. So how did that work?
So we had been meeting as a collaborative, so it would be us and Johns Hopkins, MedStar, St. Agnes, there's something called Nexus Montgomery. And again, this group had been meeting for about 2.5 years, and we had been looking to see how we could standardize some processes just to improve overall patient flow. So I knew a lot of people to call, or I was getting called by them, and then we met other people in the organization that sort of had the same role I did of, how do we sort of manage what was about to happen with COVID.
That's awesome. Joe, what happened when you got the call? Were you happy to hear from Cindy and to know you had an ally across the line?
I was positively overwhelmed and knew that I had a safety net early in the process. And that was incredibly important as we started fighting this pandemic together, as we fight it now, and as we will confront it in the future. I think, so I was delighted to receive Cindy's call. And I think one of the things that I want to say just early on, it was because of Cindy's work with the post-acute partners directly involved with UMMS that we even have any sense of integrated public reporting around COVID today. You know, it sounds so simple, but the fact that we have skilled nursing and rehab centers that enter their data daily with our health information exchange is a direct outgrowth of the Excel spreadsheets that Cindy has been working off all of these years. So when one of the conversations we had early on was how are we going to be able to scale the data, the patient-specific, patient-focused data against capacity to manage the disease, the fighting the disease, and the surge. And because of Cindy, we didn't have to start that conversation from scratch. So that was a huge benefit, and I think it's important for people to know that. A couple of the learnings early on, and I was so delighted to get that call from Cindy. A couple of the learnings early on was that our work that we had done with UMMS, Johns Hopkins, and with LifeBridge in the case of HFAM were really incredibly valuable, that we had done some work together and we were aware of the work that we were doing. With Cindy specifically, she's right. You know, we knew each other, we had done some work, and that it had been productive. And again, key in that was the Maryland Hospital Association that engaged us in that work. So that was good and important. But what was maybe even more important was the fact that the work we were doing together, Cindy and I, and the Maryland Hospital Associations and Johns Hopkins specifically, was really tough work that had that tension between critical and urgent that Stephen Covey talks about. And so we were actually in our initial work over the last year and a half, not particularly productive because it was critical work that didn't have easy answers, right? There were no easy answers. And so it was helpful not only that we knew one another and we had each other's numbers, but it was helpful that we had been working on problems that were critical that we couldn't solve. And we had that behind us because let me tell you, when you are fighting a pandemic, the things you want are a friend and colleague you can trust, data you can track, know the difference between what's urgent and what's critical, try to focus on what's critical as much as you possibly can, but know that you're fighting a pandemic where there's life and death and you're going to be dragged into the urgent. So there were days that we were talking, Cindy and I, at 7 in the morning, 2 or 3 times in the day, and 9 o'clock at night, like truly, not an exaggeration.
So what kinds of things, Cindy, were you, what were you tackling during these calls or these huddles, if you will? Was it, what's the gamut that you were trying to cover?
Well, it was quite a bit. And I want to pick up on one of Joe's themes. You know, Joe and I had a relationship, but what we developed was a very trusting relationship. So when we talk about the gamut, you know, Joe and I and the Maryland Hospital Association, you know, our thinking evolved very quickly, which I think was critical, you know, because we were able to pivot very quickly. We would go down a path and then all of a sudden, Joe would call me, we'd have a conversation and say, you know what, we need to reverse course and go down another path. And I think that's what made us successful, is moving that relationship to trust, having Joe's connections through HFAM, having my connections through the hospital, getting consensus quickly. Again, Joe is right, you know, trying to get a lot of people to reach consensus quickly, but knowing that we needed to do that. But there was an incredible level of trust built, and the willingness to pick up the phone and say, you know what, I don't think we're heading in the right direction. I think we need to go this way. And then just trying to gather all that data and then looking at, you know, I had data, Joe had data, and trying to see, okay, where is this going? Because this thing moved toward, I don't think any of us envisioned it would move this rapidly and it would escalate this quickly. And even though we had in Maryland, we were lucky, we had some planning time, unlike, unfortunately, our folks in New York. It's still, you know, how do you ever have enough planning? But it was trying to figure out how do we what's the strategy on who gets discharged from an acute and who gets admitted to a SNF, and what about PPE and how can we help with testing? And it was just all of those types of things that we had to rapidly try to figure out. And of course, Maryland evolved a little bit differently. We had sort of hot spots, and Joe and us trying to figure out, okay, why is this hot right now and what do we need to do? And then it would move to another area. So I think that was, just so many things happened. Again, that trust, and then again, that very quick willingness to not only come to consensus, but quick implementation of things. I mean, we probably accelerated our work. It would have taken us probably 3 years on a normal cycle if we even got there. And we literally did some of this in 3 months.
No doubt.
Great. So I know, Cindy, you and some of your team members also went out to the skilled nursing centers. And what are some of the key learnings from that experience that you might want to share with us?
I think that one of the things that, we know but we don't talk about is how, the high level of care that is really happening in skilled nursing, and how sick these individuals really are, which puts them obviously at high risk. They struggled with PPE and testing just like the hospitals did. The advantage the hospitals have is we have a very large supply chain, right? I'm one of 14 hospitals. I think the other thing we learned is, even though they certainly knew about PPE and all, they are not doing it because of some of the differences in the level of care. And what we found was it's just giving them confidence that they were doing the right thing, that I think was very, very reassuring. A lot of it was process improvement types of things that we were able to put some resources on the ground, which I think really turned the tide. But I think the other thing that was very important was just supporting them and speaking out at a time where, there was a lot of negativity around what they were doing. And I think that we really need to educate a lot of people that it had nothing to do with bad, infection control practices or bad this or bad that. Had a lot to do with what is the level of COVID in the community, which is where all of our workers were coming from. So.
Great. That's awesome. Joe, any other learnings from the experience that come to mind for you?
I would just add to a couple of the things that Cindy said, and she pretty much hit it spot on. But I want to sort of frame it and articulate it a little bit more. So Cindy and I were already sort of jogging pretty quickly in February. And just put things in perspective, the Maryland state of emergency wasn't until March 5th, right? And we didn't stop visitation in the post-acute world until around March 10th or March 11th, right? So by that time, we're sprinting, and we've built the trust that Cindy is speaking of. And she speaks here about something that's incredibly important. I think the general public and even some of our leaders don't realize that Maryland skilled nursing and rehab centers have built a niche in Maryland to take care of very, very high acuity patients that would otherwise in other states be in other settings like hospitals. They would largely not be at home. And one of the first things that Cindy and I started really being driven about, and I think worried about and passionate about, given our backgrounds, was that we knew that because of the types of patients and residents in skilled nursing and rehab centers, that they would be targets of this virus. And we were worried about that and driven about that and passionate about that. And we did everything we can. 2 last points on that. We really didn't learn until April that COVID could be largely asymptomatic with regard to testing.
Sure.
And that's a really big deal when you talk about the nursing resource that Cindy and her team provided in some of our centers. And again, we can't underestimate the encouragement that they provided, because we're learning in real time, right, at that point, of these huge hotspots. And we're learning that COVID has been transmitted despite the best efforts of everyone, because the folks were asymptomatic and we had been fighting the disease from a symptomatic approach. And we really needed the extra training and the pat on the back and really the bravery of Cindy's teams in these centers. It made a huge difference. So again, on the one hand, our centers have this long history of taking care of really, really sick people that, given the nature of COVID-19, are in the crosshairs. On the other hand, they don't have the experience of every person in the center being able to know how to don or doff PPE, and they're not physically set up like hospitals. Those are disadvantages. So how do you deal with that in real time as you're fighting a cruel disease? With away teams from Cindy and with some help from the bridge teams from the state. And let me tell you, honestly, just straight up, Cindy's teams saved lives in Maryland nursing homes.
You know, Joe, that's not the first time I've heard that, where we've had some other hospitals in Maryland also state that their systems could have easily been broken if there were 40, 50 patients coming to the hospital, and the communication, because where that communication was strong, which is because of these collaboratives that you have, the health systems were able to help manage and keep residents right where they wanted to be, which is at their home, which was the skilled nursing center. So that was a blessing for many involved, but I appreciate that comment quite a bit. So we know, unfortunately, that COVID is not going away tomorrow. And we know there's a lot of people working to try and eradicate this horrible virus. But knowing what we know today, are there what does this mean for kind of moving forward, and whether it's on the policy side or planning for the next surge, or kind of what do you see collaboratively, and what else do you need help with going forward?
So I think we've already put some things in place. Joe mentioned the tracking, right? So that came up quickly, but boy, you can just to know where the beds are open and where the beds are not, and who, I think, so that stays in place. We got to pilot a few things, and I mentioned this resource nurse idea where we put an RN in who would help the donning and doffing and just the flow and the process. So I think that there's a lot of merit in that. I think that there's still going to be challenges around testing and PPE, and we as hospitals have been looking at all of those things and how do we help, because again, we know that testing as well as contract tracing have to be a big part of this strategy. And as we watch what's going on in the rest of the country, we're concerned about this. How do we get enough to do that? I think that some of the, again, working on some standardization, we standardized ED transfer form. And I think that, there's some other standardization. That actually was something we'd worked on for, gosh, like 2 years, and we stood it up in 90 days. I think that some of the other things that I'm not sure that, when you talk about policy, this become a very expensive process for all of us. If you start to add up what skilled nursing homes and even hospitals had to do around paying for the testing, paying for the PPE, paying pretty exorbitant prices for staffing, and look at their cost structure, I'm still concerned about how do skilled nursing provide, again, a very sick population with all of these. I mean, this is sort of a once in a lifetime, I hope, experience. But that does drive, some of the changes. And I think it's shown us, in general, some of the weaknesses. We survived this because we had partnerships and relationships, and people were willing to get on board. And when we had conversations about, hey, what can we do to make sure that resident doesn't get moved to the ED, because we already have other people coming into our ED, they were completely on board. So, but how do we leverage that and really get some of our policymakers to really understand that we are seeing some activity from the HSCRC on some partnership grants, but I think it needs to go a little bit further than what we've seen so far. Joe, would welcome your thoughts on that.
No, I appreciate it. It's a great summary. I would add I would start with the things that we got right and that are going to serve us well in the future. I think the tracking mechanisms, I think the ED transfer form, I think the data and mining data for knowledge, I think that all of that will serve us well. The dialogues that we had relative to surge management, if we had filled all of the hospitals and filled the emergency hospitals, we had critical conversations behind the scenes on that. That will serve us well in the future. And I think actually, again, our partnership with the Maryland Hospital Association, but also specifically Cindy and I and our partnership with county health offices and with state epidemiology. I have trouble saying that, epidemiology branches. And Cindy and our work on that front will serve us well. So those are all great work in progress that'll serve us well. Now, the downside is that we're not going to be through with this until there's a broadly available vaccine, and that's a while, right? So I am worried. I am absolutely worried about future waves and future surges of COVID-19 in Maryland and in other states. There's absolutely a correlation between how hot a healthcare provider is, a hospital, a nursing home, assisted living, and its surrounding community. So communities that are hotspots have providers that are hotspots. And so that's a problem. So I worry about future surges and I worry about future waves, and it's not if, it's when, and to what extent we can change behaviors to manage those surges. So what's left to be done on managing those surges? We are not on the state-by-state basis in this country set up financially for state governments to support hospitals and nursing homes and assisted living on the costs of inflated costs for PPE, labor, and testing. We're just not. Each of those buckets just in Maryland is several dozens of tens of millions of dollars. And we're not set up to do that. We've been polling our members on testing, and the range on weekly testing is between $25,000 and $75,000 a week, right? There isn't enough money in state budgets, resources in state budgets to do that. So we're going to continue to need the advocacy of the entire healthcare continuum together, not fighting one another for funding, but going together for funding in Annapolis. And we're going to have to continue to do that with our members of Congress to get states additional aid. And we're going to have to mine the data and to adapt our clinical practices going forward. For instance, in Massachusetts, they've recently moved to not doing weekly testing for everybody in healthcare. They are testing everybody when there's a hot spot, when you have a certain level of positivity rate in the community at large. But other than that, they're doing 25% samples in each of those communities. And I think as a country, we're probably going to be moving towards that. And then finally, I want to be more explicit on PPE. So throughout the crisis, we've had different types of PPE shortages. Initially, it was masks or N95 masks. Then it was gowns. In the coming month, we're going to have a huge glove shortage. And it sounds crazy that we're talking about this, but we will have a glove shortage in this country, and we'll have to find a way to manage our way through it. And then as we enter into flu season, it's crazy that we're talking about this. We will have a glass vial and a plastic syringe shortage in this country because we're not set up to have a test vaccine for COVID-19 and for broad, regular seasonal influenza vaccinations, right? So we're in it for the long haul.
Well, I think the state of Maryland is in very good hands, and I appreciate you walking the walk and talking the talk on the phrase that everyone's been using of "we're all in this together," because you are, and you've pulled in an army of folks to join you. I know there's a lot of people standing behind you in these efforts, but I applaud the leadership and look forward to staying connected with you and working hopefully on much more positive things as we all tackle quality and move this COVID to the side as soon as we can. Thank
We
you
will.
both.
Thank you.
Thank you all.
Well.
Thank you, Sharon. Thank you, Cindy. Be well.
Take care.